So we have changed a lot in imaging because for decades the common imaging technique for multiple myeloma was conventional skeletal survey, meaning X-ray of the most parts of the skeleton to rule out osteolytic lesions, which are a major symptom in multiple myeloma. And but that's a very old technique, and even like already decades ago we knew that you have to destroy about from scientific experiments, you know, that you have to destroy 50 to 70% of the bone until you see anything in X-ray. So the sensitivity is rather low. In some areas of the body it's very difficult because in X-ray the beam goes from one direction through the body, and then the detector is on the other side, like a film or a digital detector, and you can have overlap of bones, which is also a downside of X-ray. So as most people will know, there's a technique called computed tomography, where the beam goes around the body, so we get kind of pictures from all angles. So this has a much higher sensitivity. We don't have this overlay effect, and we get a much better information with a higher sensitivity on the stability of the bone and also on the location of the osteolytic lesions. So there's this new technique, not very new technique, actually new to myeloma, or rather new to myeloma, which is called whole body low dose CT. And this is what we use now, and in the new guidelines that we just published as the International Myeloma Working Group, we recommend the whole body low dose CT as a general screening method to replace this conventional skeletal survey. This is one major point that we changed, and that is really changing also because changing the field, because we now detect the destruction of the bone earlier and we can treat the patients earlier, and we can hopefully prevent, if we know about it, we can prevent further skeletal related events. Another major thing that we could establish is that we know that after treatment we achieve very deep responses in a lot of patients that we treat, and after treatment we can now, with imaging, we can do a so-called PET-CT, positron emission tomography, together with computed tomography, to detect residual lesions after treatment. And they have been shown by people from Italy, Elena Zamanci, for example, who is giving the talk together with me, has been shown to be of very significant prognostic effect. So patients who have residual disease after treatment have a worse prognosis, obviously, than patients who have responded very well and have no residual lesions anymore.